Okay, thank you everyone for joining us today for our cardiology grand round. We have our very own Dr. Liviu Klein, who is a professor of medicine at UCSF, director of the Advanced Heart Failure Comprehensive Care Center and Mechanical Circulatory Support Program, director of the Cardiology Clinical Research, and recently named section chief of Advanced Heart Failure, Mechanical Circulatory Support, and Pulmonary Hypertension and Heart Transplant. Dr. Klein completed his cardiovascular disease fellowship at Northwestern, where he also trained in cardiovascular epidemiology, advanced heart failure, and electrophysiology. He served as director of heart failure device program at Northwestern, where he developed an integrated program in heart failure and cardiac rhythm management with implementation of a remote heart failure follow-up clinic before being recruited to join faculty at UCSF in 2011. Dr. Klein's research has focused on new diagnostic sensors, therapeutic devices, and artificial intelligence tools for patients with cardiovascular disease and heart failure. He has also studied the epidemiology of heart failure in women and sudden cardiac death in women with heart failure. Dr. Klein has been involved in a number of clinical trials, and just to name a few, is currently recruiting for CoreCinch and Rebalance HF studies. So we're really excited to hear your talk, Dr. Klein. If anyone has any questions that come up, please feel free to put them in the chat, or if you use your raise hand feature, we can ask you to ask your question in person. And this will be recorded. The YouTube link will be circulated during the next cardiology grand rounds.
Thank you so much, Joyce, for this kind introduction. And I'm really excited to share some of the work we've been doing and some of the things that are happening in heart failure. If you look at the majority of cardiovascular diseases today, I think the greatest innovation, especially in device development, it's actually within heart failure. In the last 5 years, we've seen technologies from mitral clips to intrathecal shunts, renal denervations, ventricular remodeling. So a lot of technologies to help our heart failure patients. And, the reason for that obviously is because heart failure is such a prevalent disease. It's probably the only cardiovascular disease that's still growing in prevalence at a much higher rate than any other diseases. We currently have about 6.5 million patients in the U.S. alone. 100 adults over age 65 have heart failure. Approximately 1 million new cases every year, and then the lifetime risk of developing heart failure is 20% at age 40 if you do not have an interim myocardial infarction. If you have an interim MI, the risk goes up to about 45%. So really, really high risk. And then the epidemiology has shifted from patients who were younger in their 60s following their heart attack to actually now in their early 70s. The mean age of diagnosis is 74, as more and more older patients survive longer with coronary disease. However, despite all these advances that we've made in the last 25 years in medications and devices, the mortality still remains very high. 1 year after diagnosis, about 20-25% of patients actually die. And then within 5 years, the survival is still pretty dismal. About 40% of the patients die within 5 years. It is also a disease with a very high symptom burden. The patient's quality of life is extremely poor. We have a measure called the Kansas City Cardiomyopathy Questionnaire, available in our Apex pretty soon, so we can track clinically our patients. And the score is from 0 to 100. 0 is somebody that's dead, 100 is the best quality of life. Most patients with heart failure score in the mid 40 to 50 range. So again, very poor quality of life. In addition, they have a very high hospitalization rate. And again, if you look at the survival, these are data from the Framingham Heart Study. This is the third generation or the offspring of the offsprings. And if you look at this data and you look at patients or participants in community that are healthy, you can see their 5-year or 10-year survival in light green is pretty good. If you have stage A or stage B heart failure, meaning that you have risk factors or you have maybe an abnormal LV function without symptoms, your survival is also pretty good. But if you develop stage C or D heart failure, so symptomatic heart failure, your 5-year mortality is 40%. And this is not very different from what we learned in medical school, that half the patients with heart failure die within 5 years. And again, these are patients in the 2000 era where we had ACE inhibitors, beta blockers, MRAs, CRT, ICDs, and still their survival is quite poor. In fact, if you're hospitalized with heart failure, your survival is even more dismal. Get out the guidelines registry in over 50,000 patients. admitted over 500 hospitals across the US. And what the investigators here did, they classify patients based on something called the ADHERE risk score. It's a very simple risk score that can be examined in the emergency room, looking at BUN, creatinine, and systolic blood pressure. If you have a low BUN and the blood pressure systolic greater than 115, you are at low risk. And that means your inpatient mortality is about 2%. If you have a high BUN, high creatinine, low blood pressure, your inpatient mortality can be as high as 20%. So it's a very easy risk triage score that was developed by Greg Fowler over 20 years ago. So when they are not patients in shock, their mean age is 74, half of the patients are women, the mean ejection fraction is actually 40%, and less than a third of the patients had a very low ejection fraction of 25%. But if you look at the totality of these patients, 40% of the patients were dying or are dead within a year of presenting to the hospital. And 70% is either dead or rehospitalized within a year, which, you say, well, maybe they're high risk. But if you look at the low risk group, again, patients who have a 2% inpatient mortality have a almost a 35% 1 year mortality. So the problem is we see these patients coming to the hospital and we think they are, maybe just need a bit of diuresis, and then we send them home. In fact, we have to remember that a hospitalization is a sentinel event that can, lead to very poor outcomes. Everybody's aware of, right? The huge ballooning, $30 billion, so probably over that at this point. And most of this cost is, under Medicare contract, because a lot of these patients, majority of these patients are CMS payers. So Medicare came out a few years ago with the heart failure readmission reduction program, where they said that hospitals have to implement this program, and then if their readmission rate within 30 days was higher than the national average, they'll get penalized on all the Medicare reimbursement. And if you look at this paper here, the first bar here is the risk-adjusted readmission rate before the measure was implemented, and during the implementation of the measure 2010 to 2013, and then they followed it afterward, 2013 to 2015, where hospitals were being penalized by this measure. And if you look at the absolute reduction was about 2%, so people thought that the program was a success. However, when you look at even more carefully, when you look at the same data, you see that maybe yes, you did decrease the readmission at 30 days. However, you actually increasing the mortality both at 30 days and at 1 year. So this is really not a success. So whatever the hospitals are doing to decrease the readmission, whatever strategy they're employing, actually led to higher patient mortality. The current set of heart failure is pretty rudimentary. And it really reminds me of this great movie that Steven Spielberg had 25 years ago, Saving Private Ryan, when you have a platoon of 8 people going to bring one person back from the war behind the enemy lines. And the mission was a man. And this is how I feel that our readmission programs are, right? We have pharmacists, case managers, social workers, nurses, home health, physicians, myriad of people, and their whole purpose is to really prevent one hospitalization. And we're using such intensive manpower with very low technology. And hospitals have shifted from trying to prevent hospitalizations post-discharge to trying to maybe not hospitalize patients that are decompensating at home, again, primarily driven by cost of care. So they've established IV diuretics clinics. They've established, emergency department observation unit where IV diuretics could be given, and the patients are not hospitalized. However, if you look at the data looking at outcomes in these patients, it's exactly the same. This data that I'm showing here, it's coming from the Paradigm study, right? So the sacubitril valsartan reduced heart failure with reduced ejection fraction. Data mirrors exactly the same in the Paragon study, which is a preserved DF. And if you're looking at hospitalizations, emergency department visits, or intensification of therapy as an outpatient, so that the squares, blue, green, and red, it doesn't matter where the therapy was given, the cardiovascular mortality was 3-fold higher compared to someone in the trial that has never been hospitalized or has never been treated for a worsening heart failure event. The non-cardiovascular mortality was exactly the same, but the cardiovascular mortality was 3-fold higher no matter where these patients were treated. So it really matters to prevent a hospitalization, but what it matters is to prevent a decompensation of these patients. And the remote heart failure care has been a dream of many, many people for 2 decades, but really the stars were not aligned. The patients were not really buying into it. The providers really felt that they needed to see the patients, look at their jugular venous pressure. Technical difficulties.
We can hear you now.
Can you hear me now?
Yeah, we can.
Okay,
Yes.
thanks. So I was trying to connect a AirPod to a Dell computer. It doesn't work. So before the COVID pandemic, it was really, really hard to convince, patients and physicians to do truly remote care. However, with the COVID reality, patients could not come in, and then we really have to adapt. And not only that, but the payers adapted and provided, reimbursement codes and acceptance to be able to see patients remotely. And unfortunately, what happens is not only that you have to have that remote care set up and you need data acquisition, but you really need technology to help you. And we realized in heart failure that unfortunate technology is very rudimentary. All we had was really weights and blood pressure, and some physical exam that we did over a video camera. And the problem is, again, the physicians have been fixated over a long time about treating what they call clinical congestions. We waited for patients to develop signs and symptoms, weight gain, shortness of breath, leg edema. They would call us to tell us that they have these symptoms, and then we would intervene. Again, we have systems that are structured, looking at vital signs, nursing calling patients, or interactive systems calling patients. And those things are the ones that we currently have to use in the vast majority of patients for remote monitoring. In fact, we know that what happens to these patients, their hemodynamics, their intracardiac filling pressures start to get elevated many, many weeks before they end up in the hospital. These are data from the chronicle monitor that we tested about 25 years ago, looking at the pressure changes before hospitalizations for HFrEF patients in red or HFpEF patients in blue. And you can see that the pressure change starts to happen 4 to 5 weeks before the patients develop symptoms and ends up in the hospital. So really, we need to get these measures before the patients become hospitalized. In fact, if you look at the same data in a trial of 700 patients, looking at changes in the intracardiac filling pressures over 6 months, an increase of just 5 millimeters of mercury led to an actually increase in mortality of 50%. The same patients, if whatever they were doing, whatever treatment they were getting, if you can decrease their filling pressures by 5 millimeter, the mortality decreased by 35%. So across a 10 millimeter pressure gradient, you have a doubling in mortality. Again, these are patients who are not symptomatic. So it really becomes important then to figure out what's going on and can you treat these patients before they develop symptoms. The problem is, again, the current structure of the heart failure programs is really trying to address all the issues that the patients have: medication noncompliance, dietary noncompliance, comorbidities, health literacy, social factors, all these factors that need to be addressed, which is very, very hard to do in order to improve outcomes. However, it doesn't really matter what the problems are. They will all result in a change in physiology. All these factors that will make the patient worsen or decompensate will result in change in hemodynamics. So what we have been trying to do over the last 10, 15 years is really use strategies to assess the physiologic changes before patients become symptomatic. And again, we have unsophisticated system that probably 90 plus 95% of the patients are using vital signs and weights. We have slightly more sophisticated systems where we embedded these vital signs into structured telemonitoring systems, and we have those actually tested in clinical trials. So BeAT-HF, Team HF 1 and 2, we have used biomarkers such as natriuretic peptides, and we had a trial called GUIDE-IT in trying to predict when patients will decompensate. And we have sort of true physiology assessments with multi-physiological parameters, some that we derive from implantable defibrillators and pacemakers, some from wearable devices. And then we have hemodynamic monitoring sensors that are implanted either in the pulmonary artery or in the left atrium. And again, we have trials for that. Unfortunately, if we look at all these trials, any time we try to use unsophisticated or sophisticated sort of vital signs type systems, all those trials have been negative. They have not shown an improvement in outcomes. Similar with the biomarkers, a biomarker guided strategy did not improve outcomes. However, we have some data with implantable defibrillators, and I'll show some of the data shortly. And then the only data we have so far that are truly helping in decreasing hospitalizations and improving mortality are the implantable monitoring sensors. And again, it makes sense if you think about someone decompensating, as I showed earlier, the pressures increase first, 4 or 5 weeks before a patient ends up with symptoms in the hospital. So if you can capture those pressures early, then you can make small medication changes in order to bring the pressures to normal. And then you have autonomic changes that can be captured by other devices. So one of these devices, for instance, is the Boston Scientific device, CRT or ICD, that looks at a multi-parameter approach. So what they do, they measure heart sounds. So it's a vibratory heart sound measurement, S3 and S1. They measure thoracic impedance that looks at the fluid accumulation in the chest between the can and the leads with different vectors. They measure respiration, so they have a tidal volume measurement, again, based on the patient's thoracic cavity movement. They measure heart rate, heart rate variability, activity status, and based on all these parameters, in the multi-sense study, these parameters were validated against gold standard, which are true events. And what they've seen that similar to implantable hemodynamic sensors, about a month or so prior to a patient being hospitalized, you can actually see a increase in this HeartLogic index, the multi-composite index, about 34 days prior to hospitalization. So indeed, you can detect a subclinical congestion before these patients become symptomatic. What happens if you treat subclinical congestion? So we just tested this in the multi-sense trial, and the paper is in press, where we had essentially a observational study where we implanted patients with a multi-sense device, with a HeartLogic device, and then we advised sites to use a treatment algorithm where the HeartLogic was abnormal. So if the HeartLogic level index was above 15, we advise sites to treat the patients with diuretics and vasodilators. However, this was not a randomized study, was not mandated. So some of the sites did, some didn't. And these are data that are quite interesting. If you look here, in green is the multi-sense data, where it shows in a pure observational study where you see an increase in your index and how long does it take for that to go back to normal if treatment is not necessarily changed in a standardized fashion. In the managed HF, you look at patients who are not treated in light blue. So eventually those pressures will decrease, but much, much slower, mimicking actually the observational data from multi-sense. However, if the physicians did treat the patients, you can see a much more rapid decline in the multi-sense index, in the HeartLogic index, and really recovery all the way back to normal, which suggests that treating early, again, in the absence of symptoms, may decongest these patients. Moreover, when we looked at the treatment that was done in the first 2 weeks after the HeartLogic alert was triggered, compared to no treatment in the 4 weeks after the alert was triggered, we see a clear difference here in the recovery signal. And actually that translated to a decrease in events. The study was fairly small and not powered for true events, so we cannot make a claim. However, this is going to be actually tested in a randomized fashion in 2,500 patients, or patients and physicians will be randomized to receive the alerts, and the physician will be prompted to treat the patients without symptoms when the alerts are triggered. Similarly, another company, Medtronic, has come up with a similar sort of multi-parameter sensor looking at Optivol, which is their version of thoracic impedance, activity level, arrhythmia burden, and pacing if the patient has biweekly pacing. And they're actually coming up with this TRIAGE HF index, which is low, medium, and high risk. And this index, again, it's much more imprecise than HeartLogic, for instance, or implantable hemodynamics. So their suggested algorithm was to call the patient and screen for symptoms. And then if you do that, you may be able to elicit some symptoms in patients. And in some observational studies done in Canada and the UK, that has led to a reduction in hospitalizations. Again, this is a much more much less hemodynamically competent, let's say, device, and is really trying to screen for early symptoms. The interesting part is because this is available in devices in ICDs and CRTs, you can actually move these sensors into ILRs, and currently both Boston Scientific and Medtronic are trying to see if you use ILRs, you can get the same parameters. Can you actually get patients to implant them with a diagnostic device that can last up for 2 or 3 years and get the same data and try to prevent hospitalization? So there are some advantages and disadvantages of implantable devices, right? The current devices are used for arrhythmia treatment, and the diagnostics for heart failure are sort of a byproduct, and there are indirect physiologic assessments. The good part is that you have integrated arrhythmia assessments, and oftentimes heart failure and especially atrial fibrillation coexist, and AFib can decompensate heart failure and the other way around. So it's a good integration of signals. Newer sensors as HeartLogic actually are capable of multimodal assessments, including posture, incline, and so forth. So it's possible that developing newer algorithms can using machine learning can predict in decompensation before it's clinically manifest. However, if you think about these devices, right, 60-70% of the heart failure populations don't have a CRT or an ICD because they have an ejection fraction above 35%. And that's where the movement to kind of repurpose the implantable rub recorders as diagnostic tools, it's coming to life, and we should see in the next three to 4 years if that bears to have any fruition. So that takes us to, again, the true hemodynamic decompensation, which is implantable hemodynamic sensors. The only one that's currently approved, FDA approved, it's CardioMEMS, and we've been using here since 2014. We're actually the third commercial site in the US that has implanted CardioMEMS. And it's a tiny sensor. You can see it's like a quarter that goes into the left pulmonary artery. And the patients have an electronic unit at home where they lie on a pillow, and then you get data transmitted that you can see it on the website, and we can access it and monitor these hemodynamics. The hemodynamics are quite good. The waveforms are quite good. This is one of our patients, one of the first patients that we implanted in 2014, and very, very good hemodynamic data, similar to what you would see in the cath lab. And the Champion study was the first study to look at the efficacy of hemodynamic monitoring. So 550 patients were randomized. Everybody was implanted with a CardioMEMS sensor. Half of the patients, the physicians, did not receive the information for 6 months, and they were treating patients based on signs and symptoms. In the other half, the patients were treated based on the PA pressure. So if you look at the 2 bars here, these are during the 6 months randomization of the trial. You can see the left side bar is patients randomized to treatment, where the physician did get the PA pressures. The right side, it's the middle bar, it's patients who are in the control. So you can see within 6 months, you actually had a 30% reduction in hospitalizations for heart failure. But the interesting information here is the last 2 bars. So again, the middle bar is patients in the control group during the randomized portion of the trial, which were treated via symptoms. After 6 months, all the patients were de-randomized, and the physicians actually got access to PA pressures. So the interesting portion here, if you look at the patients in the control group, after 6 months, if you follow them for the subsequent 6 months, you have a 50% reduction in hospitalizations, mirroring what you have seen in the treatment group during the randomized portion. So same patients, same physicians. The only difference is now that the physicians had access to information and treating based on hemodynamics, they were able to reduce hospitalizations for heart failure. Again, telling us that this information is very useful. What about harder outcomes such as mortality rate? Can we do something about that? Well, it turns out that again, data from Champion, if you look at mortality in the HFrEF population, so patients with a reduced ejection fraction, you have a 30% reduction in mortality if you treat these patients based on their hemodynamics. And what is even more interesting, if you look at these patients here, patients with an ejection fraction less than 40%, every single patient here in the optimized group was on an ACE inhibitor or an ARB and beta blockers. This is a trial done in 2010, 2013, so it's before the era of sacubitril valsartan. But these patients were optimally treated at that time. 60% of these patients were on mineralocorticoid antagonists, much, much higher than it's currently in real practice. So these patients were in the control group. You had an annual mortality of 15.5%. So these patients had, despite being on best medical therapy, they were, have a high mortality. If you treated these patients on top of their guideline directing medical therapy with vasodilators and use diuretics to decongest these patients, you drop the mortality by more than 50%. So you drop the mortality to 6.7%, which, by the way, is the same 1-year mortality that was seen in Paradigm with sacubitril valsartan. The difference is sacubitril valsartan enrolled in Paradigm, 70% of the patients were class 2. Everyone in Champion was class 3. So you are able to achieve with hemodynamic monitoring and management the same mortality in a class 3 patient to a class 2 patient optimally treated. So again, telling us that the importance of subclinical congestion or hemodynamic congestion cannot be underestimated. But what about real world data? These are clinical trials. Of course, we try to select the best patients. They have the best follow-up and so forth. What about, real world data? And this is data coming from Jacob Abraham's group, where he looked at 2,000 patients across US, Medicare patients, and he's done a very clever matching study. So he looked at patients who were implanted with CardioMEMS, and he matched them to patients in the same community by using zip codes. And match them by age and comorbidities. So he tried to get patients, again, treated by same physicians in the same geographical location, having the same comorbidities, the same age, and looked to see what happened to the patients after they received the CardioMEMS. So you can see here in blue is the treatment cohort, meaning the patients that were receiving a CardioMEMS. The control group is patients who did not receive a CardioMEMS. If you look at the 12 months prior to implant, their hospitalization rate was exactly the same. So they had the same number of heart failure hospitalizations before they got the CardioMEMS. However, after they received the CardioMEMS, again, same patients treated by same physicians living in the same geographical location, you had a 24% reduction in hospitalizations for heart failure in the subsequent 12 months. Patients in the community, again, very, very well matched. Not only that, but it seems that you also had a mortality reduction of 30% in the same population, which again, the real world data telling us the hemodynamic management does matter. And finally, we have data from the post-approval study. So after CardioMEMS was approved in 2014, the FDA mandated that the company runs a registry of 1,200 patients, and we are actually part of that registry, examining the hospitalization rate in patients after implant. And you can see here again, heart failure hospitalization rate has decreased by more than 50%, and that was actually maintained over every single ejection fraction. So reduced ejection fraction, mid-range ejection fraction, or preserved ejection fraction. So you have a similar reduction of 40, 50, 60% in hospitalization, again, in a real-world registry in these patients. And what's even more interesting, if you look at patients and their hemodynamics at baseline, when we look at the patients who had very low mean PA pressure at baseline, so that means those are patients who are not very congested in the trial, in the registry. So looking at patients with low mean PA pressure, patients who had sort of intermediate 25 to 35 mean PA pressure, and patients who had very high hemodynamic congestion, high degree of congestion, PA pressure mean over 35, you can see that the treatment, so the CardioMEMS implant, had a similar reduction in hospitalization. Again, 40 to 50% reduction in hospitalization, irrespective of the baseline PA pressure. And what's even more important and actually more interesting, and then you have a similar or greater benefit in patients who had low PA pressure, which are less symptomatic, so probably class 2 patient. And these are very interesting data because it was replicated in Guide HF trial. So it really tells us that preventing hemodynamic congestion over long term prevents disease progression. And these are the data that we've seen a decade ago from Mike Zile. Remember that slide where increasing PA pressure by 5 millimeters gives you 50% higher mortality, decreasing it by 30% less mortality. So again, data 10 years later replicated to suggest that this could be true. So then, Guide HF came out last year. And this is a trial that randomized 1,000 patients in class 2 or 3 heart failure. Two-thirds of those patients were class 3. Very interesting criteria for enrollment. They actually enrolled patients who were either hospitalized for heart failure, which was 35% of the patients, or patients who were just had a high NT-proBNP. And those patients on average had an NT-proBNP of about 1,400. So again, they did not have to be hospitalized, but they had a higher NT-proBNP. And this is a real world population, 40% ejection fraction. A third of the patient had true HFpEF, more than 50% PF, 40% were women, the highest enrollment in a clinical trial of women. And then if you look at their hemodynamics, they actually had very congested patients, a mean PA pressure of 35, a cardiac index of 2.1. So really what we see in real life. The interesting factor is when they looked at the trial was read as being negative. So if you look here on panel A, it's the composite endpoint or mortality, heart failure hospitalizations, or urgent heart failure visits, and you had a 12% reduction, which was not significant. If you look at just heart failure hospitalizations alone, you had a 70% reduction, again, not statistically significant. However, if we have to remember what happened during the trial, COVID happened. So if you remember here on March 13, 2020, the national emergency was declared. And it turns out that a third of the patients in the trial were actually during COVID. So they had a very, very different behavior compared to the patients enrolled and followed up before COVID. So the FDA actually asked, the trial committees to run a separate analysis looking at the population enrolled before COVID. And when you do that, you actually have a very positive outcome. So the primary endpoint, again, all-cause mortality, hospitalizations, or urgent visits is decreased by 20%, which is statistically significant. And then the heart failure hospitalizations are decreased by 28%, highly statistically significant. Again, the same number, the same hazard ratio that we've seen with every other single trial of invasive hemodynamic monitoring, suggesting that you have consistency of effects. So what are some of the advantages and disadvantages? Well, I think the advantage is that they target the end results of pathophysiologic changes. You have the pressure change that comes first, and you see that very, very early. It's very easy to understand and interpret, right? People know what the PA pressure means, and they know the lower the pressure, the better the outcomes. And you can use it in HFrEF and HFpEF. However, there are some challenges, right? There is a static measurement. It's a one-time measurement taken supine at rest, which is not how our patients live, right? They get symptomatic when they walk or when they do activities. Really requires patients compliance to actively transmit the data. You have to lie on the pillow, connected, and so forth. And it doesn't really assess physiology to assess response to exercise or response to medication. So it's a very limited piece of information that you get, which seems to be helpful in preventing disease progression, hospitalization, but it doesn't really help much in terms of targeting medications for improving patients' outcomes. And in fact, the KCCQ in the trial was not significant in Guide HF, for instance, was not statistically significant between control and treatment patients. There are some newer technologies, second generation PA pressures that have a handheld reader, and the Cordella device that we're doing the trial now, and Manda is our PI here at UCSF. And actually it's really interesting because being a portable device, you can assess patients' pressures both supine, standing, sitting, or during exercise. And we just presented data at THD last week in a patient that was doing a 6-minute walk test, and we can get these pressures after exercise. There's also second generation left atrial pressure sensors, the Vectorious device, which you have a tiny sensor implanted into the left atrial septum, and they can give you true LA pressure, again, with a slightly higher risk of implantation. But can you do something different? Can you actually get these pressures or these hemodynamics in a non-invasive fashion to address, the 95% of the population? Because it's, impossible to implant 6.5 million patients with sensors, right? If we had all the interventional cardiologists and the heart failure specialists doing nothing for a year, we barely get to implant those patients, right? So it's just not feasible. So can you assess these changes looking at non-invasive signals? So we looked at such signals, and we looked at something called ballistocardiography or seismocardiography, which is essentially the heart movement and the chest wall movement that it's triggered by the heart during a heartbeat. And although it's a central origin, you can actually capture it in the periphery, and you have a signal very similar to sort of an EKG or a blood pressure. And it started back in the 1940s. And if you remember the old scales, when you step on the scale, the needle moves. And actually, that needle movement, it's not random. It's the exact seismocardiography or ballistocardiography signal that you can capture. So you can capture it with a regular scale. And Isaac Starr actually captured on this table back in the 1940s. Was very, very unpractical to do this, although there are now companies trying to have under a mattress bed sheet that you can capture the signal. But we can capture it with scales, with regular scales, or we can actually capture it with a sensor that we can place on the chest. So we looked at some of these sensors, and you can make a very small sensor about 3 inches or so, 2 inches, that you can attach with regular ECG leads, and you can detect the signal in a triaxial fashion. You can detect the seismocardiography signal, anterolateral, head to toe, and then back to front. So when you have all these signals, you can combine them and generate a signal that can be interpreted and analyzed, and we can make some determinations. So we took this signal to the cath lab, and we had about 35 patients or so in the cath lab with both HFrEF and HFpEF, and we did vasodilator challenges. So interesting enough, when you look at the PA pressure here, you can see that with vasodilator challenges, the pressure decreases both in the PA pressure and in the wedge. And we actually seen a change in the signal with vasodilators. So the signal that we're capturing with the seismocardiography, we see a change during the vasodilator challenge. And in fact, when we plot the results of the change compared to the change in the PA pressure, the change in the wedge pressure, we've seen an almost perfect correlation of 0.8 or 0.9 with a very small dispersion. So mean PA pressure +-5 and a mean wedge of +-3. Just to give you a reference, the CardioMEMS dispersion around a true Swan-Ganz scatter measurement is 5 millimeters. So we're able to achieve the same quality or the same signal precision as CardioMEMS with a non-invasive monitor. Actually, the paper just came out today in the journal. The other thing is, can you use this signal to classify these patients in compensated or decompensated? So if we think in heart failure that somebody with a cardiac index less than 2 and a wedge more than 18, it's decompensated patients. In fact, this signal can classify patients in compensated versus decompensated. What about cardiopulmonary exercise stress testing? Well, it turns out that we can predict VO2 and VVCO2 non-invasively, again, using the same sensor. And these are our data that was published last year, looking at 75 patients undergoing cardiopulmonary stress test. And we had all sorts of patients with HCM, HFrEF, HFpEF, or just routine testing. And it turns out that, in most of these patients, we can predict their VO2 again with a pretty high confidence of ±1 milliliter per kilogram per minute. So we can do this non-invasively without having to resort to a very complicated equipment. We just need a treadmill. What about at home? What can you do at home to see if if you can figure out which of the patients are compensated versus decompensated? Well, it turns out that if you think about cardiovascular reserve, gets perturbed with exercise. So doing a minimal exercise such as 6-minute walk test may be enough to differentiate patients who are compensated versus decompensated. So a few years ago, we had a study looking at 50 patients in clinic, and we asked them to do a 6-minute walk test, and then we got the signals before and after, and then we followed their trajectory, and we saw which of these patients were hospitalized and which of the patients were decompensated clinically based on a physical exam and assessment of a heart failure cardiologist. And what we've seen when you look at the signals in totality, so without extracting any particular features, but looking at the signal in totality, you can see that the signal is very different before and after exercise. And in fact, in a compensated patient, looks very different compared to a decompensated patient. So in a compensated patient, the patient is able to mount a hemodynamic response. It's able to change their cardiovascular physiology, myocardial contraction in such a way that the signal looks very, very different. So the graph similarity score is very, very different before and after exercise. In someone that is decompensated, that cannot happen because their cardiovascular reserve is close to zero. So in fact, their signal looks very, very similar. And then when you compare the two, you can actually pick out which of these patients will be compensated versus decompensated. And again, you can use it to classify patients at home and then decide if you want to do something more. In fact, if you look at the patients at home, you can predict changes in response to diuretics. And these are patients that we enrolled, and about 20 patients who had CardioMEMS. And we looked at different parts of the SCG signal, and we looked at the signal response in response to diuretics. So the patients were at home, they were monitored with CardioMEMS. The nurses or the physicians decide to change their diuretics because the PA pressure would go up, and then we looked at their non-invasive signal, and we were able to pick up any change in the signal according to diuretics. So we actually have a difference in the signal when you give diuretics. So this can be used in the future to predict response to treatment. So where should we go from here? I think what we need for the vast majority of heart failure patients, we really need unobtrusive physiologic data collection. Again, it's just not feasible, practical, or economical to implant, implantable sensors in 6 million people. And we really need to have sensors that look at the physiology, right? They look at myocardial performance, contractility, intracardiac filling pressures, arteriovascular coupling. And first and foremost, you need to classify patients to see if they're worsening or improving. And again, these are asymptomatic patients. So you need to classify their improving or worsening subclinical status. And you also need to have a predictable response to activity and medication. You need to know if I change a medication, if I add a medication, can the signal change, and can that change make some sense so I know what the patient is responding to. And if you can do that, then you can actually personalize medications and treatment algorithms for these patients at home, and you can maintain them again in an optimal state. And something to envision in the future, for instance, one of the sensors that I've shown you, you can use it, for instance, once a week for the patient to do a 6-minute walk test, which you definitely can pick up if the patient is compensated versus decompensated. If it looks like the patient is decompensated, then you can look at that patient and you can predict their intracardiac filling pressures. You can ask them to take, medications, again, diuretics, nitrates, what have you, and then you can look at the signal and see the change in pressure. And if you see that the pressure changes by 5 or 10 millimeters of mercury after you gave isosorbide, let's say, that means that the patient is going to do well and it's not at risk for decompensation. So you can treat them very differently. You can also have the patient run, or do a formal exercise treadmill stress test. And instead of using the CPET machine, which again, very time consuming, very expensive, very specialized, you can have this patch on to look at their exercise capacity. And you can do it every 6 months or every quarter. Very, very simple assessment to predict their VO2 and VBCO2 to again, perhaps see if these patients decompensate and they need to be referred for advanced heart failure evaluation. So the strategies for heart failure management, right? The old strategies paradigm, the old paradigm is very reactive, right? People waited for patients to call and then they did something. The current paradigm, even though it's still, it's proactive, we have nurses calling the patients or asking the patients to proactively send their signals. These are still crisis management strategies, right? We're still waiting for something bad to happen or about to happen before we intervene. And I think the future paradigm is really to have a continuous connectivity with these patients, longitudinal, which will delay disease progression, will stabilize the disease, and will enable step of the care, and keep the patients in optimal health state, and keep them with a very high quality of life and out of the hospital. So I'm gonna end here, but I think what the message is really that hemodynamic congestion is what we need to target in these patients, and we need to do something to use the existing technology to predict when these patients are about to decompensate. We have a plethora of technology that's available today. It's not perfect, but available. Again, HeartLogic. We have Triage HF in patients who have defibrillators and CRTs. We have CardioMEMS. We have Cordella. But really, I think the future is in the non-invasive wearable technology, which will be much, much cheaper, much easier to use for patients, and again, can be integrated with the workflow. And again, we can go to a personalized treatment algorithm that can keep these patients at home.
Thank you so much, Dr. Klein. That was really wonderful. I'm not biased or anything, but I love seeing all of the advances in the heart failure field. So that was really exciting to hear. If anyone has any questions, please feel free to put them in the chat or raise your hand. I can start off with a question. As we have these advances in technology, in the beginning of your talk, you talked about a lot of the limitations that resulted in our need for telehealth. How do you foresee us, not isolating or not leaving out patients who don't have the resources to use a lot of these technologies? I don't know the cost of what like the CardioMEMS pillow at home and all of that is. But as we start using more technologies to continuously monitor volume statuses, how do we, make sure that we don't miss patients who don't have the resources at home?
That's a great question, and I think the two comments to that, and then I'll answer. One is, there's a lot of disparities in technology use and availability, and people are worried that you have this digital health divide. I have to say that if you look at COVID, at least personally in clinic, I was able to actually see a lot more patients that I did not see before, because people could not drive, could not afford, to drive 200 miles away, pay for gas, pay for parking, take a day off work, and so forth, and we would not see them. And usually these are patients that are in the minorities, patients who have a socioeconomic status that's very challenging. With the new technology enhancements with video visits, everyone has a cell phone, everyone has a smartphone, and we can do Zoom visits. So I think that the technology has really, at least in my experience, has helped to bridge this this divide. Now, the question about implantable technologies, they're very, very expensive, right? CardioMEMS is probably $20,000 or so to implant, and it's it's paid by CMS, but it's not paid by private insurance or by medical. So again, a lot of patients that we treat cannot benefit from this technology. In addition, I think the reality, as I mentioned, if you multiply 20,000 by 6 million, we're going to go broke just by implanting CardioMEMS. So this cannot be a solution for all the patients, and that's why we need to find non-invasive technologies which are much, much easier to use by patients and much, much cheaper, right? Probably a non-invasive sensor, it's $50 or $100, right? So much, much affordable.
Thank you. We have some questions. Dr. Grandis was wondering, anyone working on combining PaO2 sat with pressure and CardioMEMS devices?
Yeah, that's a great question, Don. And I think the short answer is no. The reason it's absolutely you need a chemical reaction or so, right, to measure O2 sat, right? So you need not just electronics, you need more than that. They are working on getting a cardiac output, looking at the DPDT rise in the PA signal. So we have actually helped them validate some of the signals to get cardiac output, and I think they will come out, both CardioMEMS and Cordella, with cardiac output measurements, which will be also very important in pulmonary hypertension patient. I know Mark actually has a study that's going to start looking at PH patients, group 1 PH patients with CardioMEMS, and that will be fantastic to be able to monitor their stroke volume response to, pulmonary vasodilators. I think Nora has a great question about signal quality and fidelity. So a lot of the non-invasive technologies, right, the HeartLogic and so forth, they have the so-called false positive rate or unexplained alert rate that is obviously bothersome if you run a practice, because you get all these signals that you can't do anything with them. And I think the field and the FDA has set a bar of 2 unexplained alerts per year as being what you should strive for. In HeartLogic, they actually have 1.4, so it is fairly reasonable and not a lot of false positive data. In our data with the patch that we developed, the signal quality is excellent actually, and it doesn't really matter where you put it on the chest. So we tried different locations on the chest, sternal, left, right. So the signal quality is quite good because we use a triaxial signal, so we can use lateral signals as well, and then dorsoventral. So it doesn't really matter as much the position.
Great. Any other questions before we wrap up? I think Nora actually.
I did. The third point in my chat, how much of the data are really totally interpretable in terms of waveform, signal quality, etc.? Can you give us a ballpark? Can we trust it?
So the data are referring to our sensor or in general?
In general, and your sensor in particular, sure.
Yeah, so if you look at, for instance, CardioMEMS, right? So if you look at CardioMEMS, Cordella, or Vectorious, which are direct hemodynamic measurements, their signal, it's excellent. If you look at the tracings, are just like you get in the cath lab. They're quite beautiful. Now there is a drift in all these signals. There's a drift over time, so you have to be alert and then have to recognize that, and you have to recalibrate. Fortunately, most of this recalibration can be done non-invasively. But there are some recalibration in about 20% of the patients. Also, if you look at their gold standard comparison, right? So if you compare the signal from CardioMEMS, for instance, with a right heart with a Swan-Ganz catheter, there's a plus minus 5 millimeters, right? So they're not perfect. They're okay, but not perfect. In our case, and then in terms of uninterpretable data with those direct hemodynamics, there are very, very few. And usually, if you have a sensor lodged in a weird position or placed in a place that cannot be read, that's why we always do it in the lab. We test the sensor position. So very, very few patients you can get uninterpretable data. With the HeartLogic, for instance, or Triage HF, again, these are indirect assessments. So there's no direct correlation with invasive hemodynamics. And they can tell you like something bad is going on, and then if you treat whatever's going on with diuretics or vasodilators, you can make that better, and perhaps you can decrease hospitalizations. That part still needs to be shown. In our case, the signal quality is excellent because again it's chest vibration, so it's very close to the heart, and what they're trying to develop is correlating with direct pressure measurements. So we're planning to launch a trial in 400 patients now, a multi-center trial looking at right heart catheterization in 400 patients and try to validate the algorithm. And ideally, we will be able to give you a pressure. So when the patient has the patch on the chest, they'll tell you this patient's wedge pressure it's 20 plus minus 2. So very, very accurate signal. Similar to the VO2, they'll tell you their peak VO2 it's 15 plus minus 1. So fairly accurate quality and signal.
I see Dr. Tierlink has a comment.
Yeah, so yeah, the CardioMEMS, again, when I presented the initial data in Champion, it was plus minus 5, their initial data.
Actually, my point was that that's comparing to the PA catheter, but when they looked at the change over time and things, that it was much more stable within the patient. So it may not be exactly correlating with the PA catheter, but the change correlates well.
Correct. Yeah, and the trend is therefore it's very, very important.
Yeah. And then my final comment was, Liviu, your work on this non-invasive stuff is really very promising, and congratulations on some excellent work.
I want to check, Dr. Chaitlin, do you have a comment? I saw that you unmuted.
Yes. First of all, it's a really interesting and exciting work that you're doing. I would like to know, how long can the pulmonary artery sensor remain in situ? How many hours or days?
Yeah, so I didn't show the way it works, but essentially it's a capacitor, so it has no battery, so it remains lifelong. And there are still patients from the original Champion trial implanted in 2008 that still have a functioning sensor. So you have an inductance that's outside the body, that that pillow that the patient's lying on, that's powering the sensor. So the sensor being without a battery can last forever, and it doesn't really thrombose either. It endothelializes within about 30 days or so. So it's fairly durable.
Wonderful.
Well, thank you everyone for your participation. And again, thank you, Dr. Klein, for the great talk. I'll see everyone next week at our next cardiology grand rounds.